right, let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I will be your host today, and I'm a filmmaker that's been working with CCF for a decade, folks. That's 10 years. That's 10 years. I can't believe it. To create video content, whether it's produced videos or live video series like this, all with the same mission in mind, and that is to help spread awareness and education about neuroendocrine tumors. That is what we are here to do. That's what we're here to talk about. This is Luncheon with the Experts. If you are a friend of the foundation, a regular to the show, you probably are already doing it. Oh, I see it. We have Canada in the house, Michigan, Ohio, Wisconsin. Let us know where you're signing on from in the world. I say this every week, and I will not stop saying this. My favorite part of the show has got to be the reach that we have. And not just, by the time tomorrow rolls around, thousands of people will have viewed the show. But the people who tune in live that aren't just on the Eastern, just in the US or Eastern time zone, like me and my guest are today, but people in Australia, people in India, people in South Africa, people all over the globe at times where they should be going to sleep are tuning in for Luncheon with the Experts. Folks, if that doesn't tell us that we are doing a good job, I don't know what does. And our job is to serve you and help answer some of your questions. So that makes me very proud that we are doing a good job. And we've been doing the show over a year now. So as we do in every episode, we have to thank our presenting sponsor, Tercera Therapeutics. We absolutely could not do the show without their support. We also always like to say this disclaimer at the top of the program from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that you all at home, haven't been created or suggested by the sponsors of Lunch with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they may make about their health or treatments. So that last line is the real takeaway there. We're going to answer some of your questions. We're going to give you some good advice and hopefully some direction on your journey, but we certainly don't know your specific case. So take those answers, take that general advice and direction back to your home team who does know your specific case and make the best plan for you moving forward. As we all know, and we talk about every week, this disease is unique for every patient. We all have our own unique paths with it. So take this information back to your home team, make the best plan for you moving forward. I'm very excited about our guest today, who is, I think it's safe to say, a friend of mine now. We've worked together several times over the years that I've been working with CCF. And I've been working with CCF, as I said, for 10 years. And our guest today and I forget when we first worked together, but it was a long time ago at a conference, maybe the New Jersey conference or something like that, and have continued to work together. In fact, he was on the show back in January. Today, our guest is Dr. Jerome, aka Jerry Zacks. How are you, Dr. Zacks?
Very well. Thanks, Rain, for inviting me once again. I thought after the first time you'd say no. Not again.
We'll never get sick of you. No, absolutely, my friend. It's good to see you again, and welcome back to the show. For those that didn't see you in January or that may not know you and your work, could you tell us a little bit about yourself and what you do and what role you fill in the neuroendocrine tumor community?
So I'm a board certified internist and cardiologist. And quite a few years ago, about 30 years ago, Richard Warner, who's the most senior person in neuroendocrine tumors in the world, I believe, he and I were both skiers and friends. And he asked me if I would help take care of patients with the carcinoid heart disease. Mm-hmm. And I said, sure, I'd love to do it, but I don't know very much about it. And he said, well, you'll learn. And that was my start. And I would say about 50% of my practice is with patients with the carcinoid syndrome or neuroendocrine tumors.
All right, good to know. And I see someone, Dorothy, already says, so happy Dr. Zacks and Rain would never have had my tricuspid valve fixed without Dr. Zacks. So you're already getting some love, my friend. And also, we got to give praise and shout out to Dr. Warner, as you already did. Founded the foundation over 50 years ago at this point. I've also worked with him quite a bit and enjoy working with him too. I didn't know that you were both skiers. I knew he was. I'd seen some of his old pictures. I didn't know that you were as well. That's interesting.
I was a competitive snow skier,
what?
jumper, and water skier.
Wow, that is quite impressive. I feel, yeah, that's it.
And even at my old age, I can still barefoot water ski.
What? Oh, I grew up on the water, so that, yeah, I definitely get that. That's pretty cool. We might have to talk about that on another show. That's a whole nother episode right there. Folks, Luncheon with the Experts is your chance to get a one-on-one virtual session with an expert, with a specialist in this disease. That is invaluable. That's really getting some answers to your question. Now we're going to have this show reposted on Facebook starting on Monday. We'll repost it to YouTube. You can always refer back to this. Someone else who didn't see the show live can watch this show, and there will obviously be benefit from that. But the real benefit is from being here live and getting those questions across. So you can go ahead and start sending in those questions. We're going to do our best to get to all of them. If we don't get to all of them, please, I urge you to reach out to CCF either here on their Facebook page. You can private message them. You can reach them at their website, carcinoid.org, and they will give you the information that you need, or get you the information of the person or people who can get you the answers that you are looking for. Secondly, back to the benefit of being here live for the interactive session, we want to get as many people here as possible. That's the real value that I think that this show offers, plus the community that we have cultivated here. So if you know someone that would benefit from the show, tag them in the comments, share the video to their page, text them, email them, Snapchat them, whatever you have to do. Let's get as many people here as possible. Okay. And one more thing I'd like to ask you all to do. Every week you've been doing a great job of this. I really appreciate it. If you see a question in the comment section that you also have, or that you're interested in learning more about, there's a few things just below the question. There's an option to like it or love it. There's a few emojis that Facebook gives you the option to use. They all work effectively the same for me. And what that does is upvotes that question. If I see there's a demand for it, 7 people have liked this question, I'm going to know, hey, we might not get all the questions, but I need to get to that one. So that just helps me, get to those questions sooner if we have a lot of people interested in that, because folks, we get hundreds of questions every week. So it is, it's a good problem, right? We keep the show going on, but we really want to get to as many of those questions as possible. So that would help us help you. Finally, we always like to ask if you have downloaded CCF's free Net Cancer Health Storylines app. This app is amazing. It makes it very easy to record your symptoms, your moods, your medicines, your nutritional concerns, all of that. So if you haven't checked that out, do so now. We will put a link in the comment section. And to that point, anything that Dr. Zacks refers to today, an article, a medicine, or any resource, we'll try to put that in the comment section as well, in a link, so that you can easily find that and you don't have to jump out and open a Google window and search for it while you're trying to listen to the show. We will do the work for you, folks. All right. Send those questions in. Let's get started. So, Dr. Zacks, I know that you are pretty familiar with the overall NET disease, and you're willing to take on questions from a wide variety of angles in that disease, pertaining to that disease. But your specialty is with the heart. And I think I'm certainly not an expert, but I have worked in the disease for a while. And I think some people may, if they're new to this disease, may not know very much about how the heart can even be involved in a NET tumor. They think, gut, midgut, liver, pancreas. We know there's lung nets, but let's lay a little bit of foundation here. Like, how can a neuroendocrine tumor impact the heart? In what ways can a NET impact the heart?
So basically, neuroendocrine tumors can be functional or non-functional. Mm-hmm. And we're talking about functional tumors. So let me tell you what that is. Tumors which secrete substances which have an effect on either the body, flushing, diarrhea, heart rate, heart rhythm. Those are called functional tumors because they secrete these, what we call vasoactive substances. And those which don't secrete these substances are called non-functional tumors. And so basically, when we talk about carcinoid heart disease, we're talking about a disease in which a primary tumor metastasizes, usually to the liver.
Mm-hmm.
And in the liver, multiple metastases produce a substance called serotonin, along with other substances. Serotonin, in particular, in high concentration, travels from the liver directly through the inferior vena cava to the right side of the heart, affecting the two right heart valves, the tricuspid and pulmonary valves. And then when the blood travels from there to the lungs, the serotonin is deactivated. We don't know exactly how, but it's carried in platelets. And when it gets to the lung, the serotonin is deactivated. So the blood returning to the left side of the heart usually does not cause the adverse effect on the left heart valves. However, if you do see left heart involvement, you have to ask, how could that be? And there are three major possibilities. One is they have a hole in the heart called the patent foramen ovale, which allows blood to go across from the right heart to the left heart. The second possibility is that you have a pulmonary primary, which is producing a high amount of serotonin, and that can affect the left side of the heart. Or you have such a high serotonin level that even though the lung is doing its part, it can't completely deactivate the serotonin traveling through, and you can get left heart involvement there.
Folks, you're in for a treat today, Dr. Zacks. That was very, it was complex, but you explained it simply in a way that was easy for me to follow, especially using the visuals like that. So I really appreciate laying out information like that, and I know the people will too. So I'm excited for your answers today. Let's go ahead and start taking some questions because we have a lot already rolling in, and I want to make sure that we get to them. So Michelle says that my husband has numerous tumors in the liver and extensive in bones, has had PRT. Doctor said Doctor said at 6 months out, okay, that was an abbreviated term. Doctor said at 6 months out from the last PRT session, sometimes they see spreading extensively. Is this normal? You follow that?
Well, there is a phenomenon in which when you do repeat imaging, it looks as though all of the lesions are larger on the imaging. However, the explanation is that in the ensuing months after PRRT, those tumors which have been partially killed create inflammation around each of those metastases. And so on imaging, they look larger, but in fact, in later imaging, you'll see the effectiveness of the PRRT. So it can be a false effect, and it's common. At all of our tumor board meetings, which we have once a week, Ed Wolin emphasizes the fact that when it looks worse right after PRRT, it can simply be that it was effective and it's just inflammation around the metastases.
Wow. Interesting. Glad to know that. Thanks for your question. Hope that helps. So Mary says, as a person with a PNET, a pancreatectomy, 3 small spots on the liver, but no carcinoid symptoms, do they need to worry about their heart?
That's a very good question, and it involves checking biomarkers.
Okay.
And perhaps, and it's not very complex. There are only a couple that are really, really important. And one is the breakdown product of chromogranin A. We no longer recommend chromogranin A itself because that's affected by antacid PPI medications. We recommend the breakdown product, which is called pancreastatin, which is unaffected by PPIs. And that gives a sort of indication of the amount of tumor secreting these substances. And if you follow it over time, it correlates with tumor growth or tumor benefit from therapy. The other thing that I consider most important, because I'm a cardiologist, is serotonin. And serotonin should be measured either by doing a blood serotonin level or a plasma 5-HIAA. Now, you notice I emphasized blood and plasma, and I didn't say urinary. We do not recommend the 24-hour urine collection anymore because the blood tests are more accurate, and the urine test is kind of complicated for a patient to carry out for 24 hours. There are problems associated with it and lab errors that occur. And in some of the published studies that I did, I had at that time only access to 5-HIAA, and I showed a patient with a dramatic effect from reducing serotonin. But when we measured the 5-HIAA in that patient, it came out high on one occasion, very high. So the 24-hour urine collection is not very accurate. Those are the major biomarkers that I recommend. There are multiple other, there's a whole panel of biomarkers that your oncologist might do when they first see you, because they want to know which biomarkers are being produced by your tumor. But in terms of carcinoid heart disease, I'm doing pancreastatin and serotonin or plasma 5-HIAA.
Got it. Thank you. Thanks for your question, Mary. Hopefully that helped. Karen says, sorry I'm late. I hope I didn't miss anything. I don't think that you did, Karen. I'm glad to have you here. But just remember, for Karen and everybody else, the show will live evergreen here on the videos tab of the Carcinoid Cancer Foundation Facebook page. You can always refer back to it. And if you just missed the first few minutes, then that's okay. You can go see that easily. And then starting on Monday, we will republish it to YouTube for anybody who doesn't have Facebook. So hope that you get to watch that again and see anything that you might have missed, which I don't think it was too much. Folks, if you did join us late, we are here with Dr. Jerry Zacks. This is Carcinoid Cancer Foundation's Luncheon with the Experts. We're happy to have you. I just want to give a special shout out to Rebecca. I see that you are tagging people trying to get them into the talk today. That's what we love to see. We appreciate you, Rebecca. Speaking of Rebecca, she has a question. What is the other ways of knowing if treatment is working other than the Gallium-68 scan?
Speaking of scans, we have a new one, the copper-64, which has a similar representation of tumor in the body to the gallium, but in some instances, it's a sharper image and a little more sensitive in some cases. So your doctor may choose one or the other, or we're sometimes doing both because we're doing studies to compare the two. There's other imaging, however, that we always do, and that is either the MRI for the abdomen and pelvis and the CT scan for the chest. And so we put all of these together when we have our tumor board and present a case in terms of making decisions, so that we can include the nuclear medicine scans and the MRIs and the CAT scans, and they're all very, very useful. In some instances, with my carcinoid heart disease patients, we can do a cardiac MRI.
Got it. Thank you. And thanks, Rebecca. CD has a question, and it is, my cardiologist here in Rochester has read up on this a lot, and he knows a bit about it. But I'm concerned that a regular cardiologist may not be able to handle may not be enough to handle. Got it. I'm concerned a regular cardiologist may not be enough to handle handle carcinoid heart disease. Do I need to seek out a NET specialist in this field, or is a cardiologist, any cardiologist, enough to detect this?
So we always like to include the local docs as much as possible. Because if you think about it, that's the doc who's on the front line. He's there for you all the time. And we enjoy working together, and we try to give out as much information to continually update them, educate them. So that's our preference, is that I would say that if you have a neuroendocrine tumor, you should, as soon as possible, arrange to see a neuroendocrine tumor expert so that you can get the latest in terms of your available evaluation and treatment. However, that specialist should be one who enjoys working with your local doctors. And that's the best possible combination. And I must emphasize, there are international studies now which have shown that this is really a team job. This disease requires team care. It's much better than a single doc trying to manage all aspects. When we have our tumor board meetings, we have approximately 20 different specialists at the tumor board meeting because we need all of them. None of us can know everything about everything.
True. Absolutely. Next question from Wendy. Wendy is a friend of the foundation. Good to see you, Wendy. Wendy says, I've been diagnosed with carcinoid heart disease. Just had my first echo. Left valve, 63% fraction. Left ventricle smaller than the right. Is there any concern there as far as you can?
Yeah, that's a good observation, because normally the right ventricle is a lower pressure ventricle and is smaller than the left ventricle. So that implies that the right ventricle may be dilated. In other words, having a high pressure. And in carcinoid heart disease, the cause is the scarring of the two right heart valves, tricuspid and pulmonic valves. They get scarred. And so they don't move, open and close properly anymore. They often get fixed so that they're constantly leaking and narrowed. And that creates an inefficient heart pump. And the result is an elevated pressure on the right side of the heart, trying to compensate for these valves that are not working very well. So just knowing that the right ventricle is larger than the left in somebody with carcinoid makes you think you better determine why that is.
Got it. Well, as I suspected, Dr. Zacks, we have a lot of questions about the heart today, which I think that makes sense. But we also have one, which you and I chatted about a little bit before the show. Mary says, what are you thinking about getting the third COVID vaccine? So the booster shot.
So, by the way, just yesterday, there was information coming across TV, either CNN or the NBC cable network, saying that they are considering dropping the interval from your second shot to the booster down from 8 months down to 6 months, because the data is showing there is a drop off over time of the immunity, the antibodies. And especially somebody who might be immunocompromised, and that includes many of our patients, I would get it as soon as it's offered to you. And I would remind your doctor that you have a disease that is dependent upon immunity to fight cancer cells. And I would say get your booster as soon as you can.
All right. Thank you for that. And thank you, Mary. Okay, Nancy says, I just had my primary and multiple liver mets removed at Penn in May. It was a very successful op. I had no indication of heart disease at the time, but I had an episode of SVT weeks later with a normal EKG in the ED. With no visible tumor and a low-grade SM bowel net, is carcinoid heart disease likely? I know that you can't speak to my risk in particular, but in general. And let me know if you want me to repeat any of that, because it was
No. That's really an excellent question. And so tumor has been removed. And so what you would like to know is, did you start out with an elevated serotonin?
Mm-hmm.
And did the serotonin go down following surgery? So if, for example, a normal serotonin is 250 or 220 something or less, if that's normal, and if your serotonin has been above that, and we've seen carcinoid heart disease in patients with 250 serotonin. So if you started out with an elevated serotonin and it did not go down to normal after surgery, you're at risk for carcinoid heart disease.
Got it. All right. Well, thanks for that question. Next question from Rebecca. I never had HTN, which is hypertension. Is that correct?
That's correct.
Until diagnosed with NETs. And now I'm on 3 different blood pressure medicines. I'm concerned about what this cancer will or can do to my heart. What, if anything, can I do to prevent carcinoid heart disease?
Okay, so number 1 is to focus on serotonin, but I just want to make some other comments.
Please.
About the 3-drug treatment of hypertension.
Mm-hmm.
You should view your body and hypertension as you would a pilot flying an airplane. Okay. And a good pilot, in order to prevent a crash, looks at all the instruments fairly frequently. Mm-hmm. And if anything is a little bit off, the pilot makes a correction in order to prevent a crash. So that's what we're doing when we're treating hypertension. What we're focused on is trying to keep your blood pressure as low as possible, usually 125 to 130 or below for the systolic. And blood pressure should be measured sitting and standing. Because if you only measure blood pressure in one position, you're learning nothing about the blood volume status. You don't know whether you're dehydrated, fluid and salt overloaded. And as soon as you measure your blood pressure sitting and then measure it standing, if it falls, you're probably dehydrated. If it goes up, you're probably in heart failure or at least some salt overloaded. And if it remains the same and it's a normal level, you probably have a good fluid status. And that tells us something about how to treat it. Now, so you mentioned 3 drugs, and I want to shift your focus to the instruments, your blood pressure. Mm-hmm. If your blood pressure is well controlled and you only require 2 drugs, that's fine. But if it's not, and you require a 3rd or even a 4th drug, take whatever it takes to prevent a crash.
Awesome. Thank you for that, Dr. Zacks, and thank you for your question. Moving forward, from Melissa, is it possible to have carcinoid heart disease with no liver involvement? I have 2 mechanical valves and an unknown primary. I had a carcinoid tumor removed from my ovary, but was told that that was not the primary.
So that is such a good question. And Michael Shafir, a surgeon from Mount Sinai, published, I believe it was 60 cases that he operated on in that situation. If you have carcinoid heart disease, in the majority of instances, it's coming from metastases in the liver. If you see no tumor in the liver, you must look in the pelvis for an ovarian carcinoid primary. So the majority of patients who don't have any tumor in the liver, but they have carcinoid heart disease, have a tumor coming from the pelvis. And that drains directly also into the inferior vena cava, which is how you get it to the heart valves.
Got it. Thanks for your question, Melissa. I hope that helped. Moving forward with Sheila. Sheila says, please discuss wildly fluctuating blood pressure and NETs. I get episodes of hypertensive, hyperglycemic episodes, and my blood pressure wildly changes between something like 62 to 35 and up to 208 over 69.
So that's an excellent question, and one that we're faced with frequently because neuroendocrine tumors produce vasoactive substances which can affect the blood pressure. Now, don't forget that there aren't just midgut tumors. There are tumors in the upper gut, we call it the foregut. There are tumors in the colon. There are tumors in the adrenal glands, the thyroid gland, the pituitary gland, that can all produce vasoactive substances. A pheochromocytoma, for example, usually associated with an adrenal gland, produces catecholamines, which can cause these sudden increases in blood pressure. And there are tumors which produce vasoactive substances, which are potent vasodilators, which can suddenly drop the blood pressure. So if you're having this fluctuation and you already know you have a neuroendocrine tumor, tell them to scan for other sites of possible tumor and to do all of the blood tests for the vasoactive substances, which can cause blood sugar elevation or decrease, blood pressure elevation or decrease. All of these things neuroendocrine tumor specialists deal with every day. That's why if your doctor is a little bit uneasy about doing all this testing, see a neuroendocrine tumor specialist. Get these, this is just a single visit. All of these blood tests will be done. As soon as they hear your history, you'll get answers, and then they'll define what kind of imaging is the best for what they're looking for.
Folks, we were about halfway through today's show with Dr. Jerry Zacks. I hope that it is very clear the value that he is bringing to us in our show today. I'm learning a lot, and I hope that you are as well. And we see a lot of questions in the heart department, which makes sense. We're going to keep moving forward. Keep sending your questions. We're getting a lot of great answers today from Florian, our friend from Germany. Florian says, I know that with lung nets, the carcinoid heart disease can arise without the liver being involved. In lung nets, histamine is also sometimes produced by the tumor. Can histamine also be responsible for carcinoid heart disease, or does serotonin only damage the heart, or only serotonin damage the heart?
So it's thought that predominantly serotonin and perhaps substance P, they call it, in terms of histamine, that's often involved in the flushing associated with the carcinoid syndrome. The lung net very often can cause carcinoid heart disease without liver involvement, but that would generally involve either all the valves or at least the left heart valves.
Got it. Thanks, Florian. From Joe, will nets have an impact on a heart with a leaky aortic valve, or will the leak impact the net?
That's a great question because it brings up the issue of who should get an echocardiogram. So we have a policy at our neuroendocrine tumor group at Mount Sinai that anyone with a neuroendocrine tumor should get a baseline echo. Well, you could actually argue that anyone who comes in with a new disease that's in any way life-threatening or serious should get a baseline echo, but that's basically it. Our neuroendocrine tumor patients get a baseline echo because we realize that approximately 50% of people with the carcinoid syndrome will, during the course of their disease, develop carcinoid heart disease. They may not need surgery, but if we look closely at the echoes, we can usually find it if serotonin is elevated. However, this patient is asking about the aortic valve, which is uncommon in carcinoid heart disease. However, don't forget, all of these patients have all of the other cardiovascular issues. And it's very important to look at your echo and say, well, what else besides carcinoid heart disease does my patient have? Very often, they have aortic valve leaks from various causes, or stenosis, narrowing, and mitral valve disease. Or maybe because they've had uncontrolled hypertension, which might not have had anything to do with a neuroendocrine tumor, But maybe if they went for a long period without control, they have some degree of heart failure or decreased function of the heart. It's very important to diagnose that because most of those problems are easy to treat. And it increases your lifespan if you don't just focus on your neuroendocrine tumor, but take care of your whole body.
Well said. So we've talked a lot about serotonin already today. Rebecca has a question that says, my doctor says I have carcinoid syndrome, but I've never had my serotonin checked. Is this something that I should ask my doctor about? And if so, how often should it be checked?
So if you get your serotonin checked and it's normal, and if you're not having a carcinoid syndrome, that's commonly flushing and diarrhea, perhaps if you get it checked once a year, that would be useful because tumors can change and start producing substances that weren't there earlier. So I think that it's very, very important to get baseline biomarkers. And if your doctor does not feel comfortable doing them, that's the advantage of seeing a neuroendocrine tumor specialist.
And is there a way to lower your serotonin levels?
Oh, yeah, that's a great question. So up until 5-6 years ago, or maybe even a little earlier when we started to do research with the drug Zermello, we always discussed with a carcinoid heart patient who was about to undergo surgical replacement of his valves, we always discussed the issue. Should we give you a mechanical valve, which requires lifelong anticoagulation, or a tissue valve, which does not require that? And so it's less risky when you undergo surgery if you don't require anticoagulation. But we showed in our study at Mount Sinai, and the Jerusalem group showed in their study, that anywhere from 46% of patients who got bioprosthetic valves at that time would get recurrent fibrosis, because even though they operated on all of our patients to do tumor reductive procedures and all of the procedures that they have to reduce tumor, chemotherapy, everything, only one of 27 patients that we reported on achieved a normal serotonin ultimately. So we saw this recurrent disease occur frequently until Zermello was approved by the FDA. And now in the majority of our patients, we get a fairly dramatic decrease of serotonin if they go on Zermello. And I won't bother you too much about this, but I'll just mention some important things about Zermello. Zermello is a tryptophan hydroxylase inhibitor. That's the first step in the formation of serotonin from tryptophan, and it blocks the formation of serotonin. And if you're taking this drug and you get abdominal pain or vomiting or constipation, we tell you stop the drug, wait, we'll tell you what to do when you have relief, how to prevent constipation in the future, and then we resume the Zermello at a very low dose, whereas it's usually 3 pills a day. I'll start out with either 1 pill a day or maybe even a half a pill a day. And then as they tolerate it, go up and prevent. We're giving them measures to prevent constipation. I just wanted to give people a feel to the idea that it's a very important drug. It can produce side effects. You do stop the drug if you get a side effect, and you call your doctor right away. And an expert who's using this drug all the time will guide you in resuming it so you ultimately get the benefit of the drug.
Got it. Thank you for that thorough answer, and I hope that that helps. That question actually came from Jesse. Next question from Karen. I've had high and low heart rates since starting on octreotide in 2019 and then being switched to lanreotide. My heart continues to go up and down. The other day, it jumped to 209, according to my iWatch, and it has gone as low as 39. I understand that this can be fatal. Yikes. What should I do? Stop the injection or what? I have stage 4 carcinoid syndrome.
So it might be that this patient is having paroxysmal arrhythmias, intermittent rapid beating of the heart. And then when it stops, there's a pause. So the heart rate goes very, very low. And so what we always try to do is to document the severity of the arrhythmia by doing Holter monitoring for either a day, a week, a month, however necessary to capture the extent of the arrhythmia. And then we look for the underlying cause. Very often it's the valve problems or hypertension that's the underlying cause of these arrhythmias. And then we have to decide, do they need a special drug? Do they need better treatment of heart failure? Do they need valve replacement? Whatever it is, we try to take care of the underlying cause and then see, do they still have the arrhythmias? If they do, and if it includes very low heart rates with dizziness, we may have to pause the drugs, put in a pacemaker, and that protects them from the low heartbeat. Then we give them whatever suppressive drug they need to suppress that rapid beating.
Got it. Thank you. Next question from Jennifer. Jennifer says, I was diagnosed 30 plus years ago. My cardiologist does not currently detect any heart involvement. So what concerns do you have regarding long-termers like me?
So a patient like that probably should have an annual echo to look for all of the other heart problems, like effects of hypertension, deterioration of the ventricular function because the blood pressure was not kept under good control. Look for any developing valve problems. In other words, things that are perhaps not even related to the carcinoid. If the biomarkers show a normal serotonin, it is unusual for someone to ever develop carcinoid heart disease.
Got it. So Patty asks, Dr. Zacks, can you talk about MEN1 and heart disease, please? Thank you. And I know that we tend to talk about MEN1 frequently on the show, so most people might know what that is. But for those that might not, could we establish what Patty's referring to with MEN1?
So there is a gene that is called the MEN1 gene, which can be tested for. But this is multiple endocrine neoplasia. And so whenever there's a suggestion of more than one type of neuroendocrine tumor, we should start thinking, could it be an MEN syndrome? Mm-hmm. And so we should include in the imaging the head for the pituitary gland, the thyroid and parathyroid glands, the pancreas, the adrenal glands. We should have sort of an open mind in order to look for the totality of involvement with different types of tumor. And then, of course, you have to take a family history and find out, did anyone else in the family have tumor? And it's important because you want to be able to tell young people what is the likelihood statistically that they will have the genetic abnormality. And then you can prompt them to get the appropriate testing.
Got it. Thank you, Patty. Appreciate that. Next question from Tyler. Folks, we have just about 15 minutes left. We are moving right along. Great questions today, by the way. Also great answers, Dr. Zacks. Tyler says, how do you know if your heart problems are from carcinoid? Had lung carcinoid tumor without any involvement of the lymph nodes. It was growing for 3 years before diagnosis. Had a normal echo prior to the tumor showing, and now I have a leaky heart valve. Never had any hormones tested. Should they be?
There's no question of it, because you want to determine, is this really related to the carcinoid tumor substances? And if you have normal biomarkers, it's very unlikely that it's caused by the tumor. And so then you'd want to focus on other possible causes of leaky valves.
And Jesse says, what if serotonin levels are normal, but carcinoid symptoms, carcinoid syndrome symptoms, I'm guessing, happen every day?
So you still want to do your echo, because there are rare instances in which a person with a normal serotonin has carcinoid heart disease. And we're not sure if that's a receptor disease, which Dr. Warner has brought up, or some other substances which are causing the typical fibrosis inside the heart. But your echocardiogram, this is one situation in which the echocardiogram is considered to be 100% sensitive and specific for carcinoid heart disease, because we're looking for specific thickening and shortening of the valve apparatus and associated with leaking or narrowing of the valve. There's a typical picture on the echocardiogram of carcinoid heart disease. So even very mild disease can be picked up with an echocardiogram performed by an experienced echocardiographer who understands carcinoid heart disease.
Awesome. Thank you. Next question comes from John, and John is here almost every week, I believe, on behalf of his wife. Good to see you again, my friend. Thanks for coming back to the show. And John says, my wife suffers from the disease, started in the bowel to the liver, several tumors, moved to the right side of her heart, damaging the right side. Diagnosed in February, she gets the 28-day lanreotide injections, which raised her sugar level. Now takes other medications to reduce it. They can't seem to do anything until the heart valves are replaced. It's frustrating waiting for something to be done. She is in stage 4 now. Is it common for the process to take this long, or is this normal?
So first, it's such a wonderful question, because it points out so many different aspects of the disease. And what we look for on the echocardiogram in terms of making a decision, what do you do first? Reduce tumor or fix the heart? It's quite simple when you do an echocardiogram by an experienced technician. We are looking at the inferior vena cava, and the normal inferior vena cava moves with respiration. The size becomes larger and smaller. And if the motion is greater than 50% of the diameter, that's a normal motion. However, if you have right heart failure due to carcinoid heart disease, the pressure in the inferior vena cava is elevated, preventing this respiratory variation of the size of the inferior vena cava. If we see a situation in which the right heart pressure is elevated in the inferior vena cava, it means the liver is under an abnormally high pressure. And if they do anything in your abdomen, you have a high chance of bleeding. So in that situation, we fix the heart first. So the echocardiogram helps with that decision of which one do you fix first.
Got it. Thank you. Next question from Carrie. We're continuing to talk about serotonin. Carrie says, what is a normal serotonin whole blood level? I just looked at my NIH result from 2018 and it was 296.
So normal in our lab is, I think, 222. But it doesn't vary very much from lab to lab. And in your lab, it may be a higher level. It's very important to check the normal range. I did see one lab in which the upper limit of normal was 400. So there are exceptions. It's important to check the normal level range, which is given with each lab result. And then you can judge whether your serotonin is elevated or not.
Got it. And Carrie, I see that you commented back that you hit enter too soon. But yeah, we just clarified it for you. So hopefully that helped. Appreciate your question. Let us know if you have any more, Carrie. Next question from Linda. If you had a primary tumor in the gut and metastases to the liver for 23 months, all PETs showed no growth. Now you have slight growth to 2 liver areas. Do you feel like you should start an additional treatment other than the octreotide now, or would you wait a bit to start additional treatment such as Afinitor? Have had cardiac ultrasounds. Everything is normal. would this slight growth increase cardiac status?
The answer concerning the heart is involves testing the biomarkers. Just to answer the question whether you're really at risk for carcinoid heart disease. But the answer, even if you have non-functional tumors, concerning, this is what we debate about in each individual case at our tumor board meetings every week. If you have only minimal progression, should you move? And the decision involves scanning the entire body to see whether the bones or the lungs or any other part of the body is involved, looking at how many tumors there are in the liver, and looking at whether or not the primary tumor has been removed. Because it has been shown by Dr. Pommier, who is a surgeon, a neuroendocrine tumor surgeon, it's been shown that in those patients in whom he removed the primary tumor, their life expectancy was longer than those in whom he left the primary tumor in place. So we now have this principle, and it's not just in neuroendocrine tumors. Now in prostate, they just switched over to our way of doing things. We have a principle that you should find the primary tumor. Sometimes it's only the size of one little piece of rice, but you should find that primary and, if possible, get it removed, because it influences the passage through lymphatics and blood of tumor cells and forming other metastases. So in general, try to get rid of the primary. Look at the total amount of tumor that's involved, and then you make a decision which way is going to be better, watching for a bit longer or instituting some tumor repressive or ablative procedure to reduce tumor burden.
Okay, thank you for that. And I'm getting a lot of praise from the answers that you're providing. A lot of people are really enjoying this. Before, we still have about 5 minutes left, but before we go, I wanted to give you a chance to talk about, we talked before the show about something that you've been working on that is involved in the space, but a little bit different for you. Could you tell the folks at home a little bit about your invention, basically, that you're working on a patent for?
Yeah, basically, I noticed that when patients had edema of the legs, which can be caused not only by carcinoid, but can cause by heart failure, it can be caused by venous disease, anything causing edema of the legs. Very often, in addition to giving diuretics, we prescribe compression stockings. And it's been shown that 60% or so of patients using compression stockings cannot continue to put them on and off. It's difficult for many of us to get them on and off. And so I focused on that over the last 5-6 years or so, and came up with the idea of creating a stocking, which you just pull up, very easy to pull on, and then you turn a dial and the whole thing pulls together. And I just got a patent on it. I have not, because I'm a cardiologist, I have not had time to do the business side of it, but I hope to focus on finding somebody who's interested in manufacturing and distributing it, because it would be a great help if we can keep costs low and make it readily available.
I just think that's so cool. I wanted to bring attention to it. Folks, he is a cardiologist, a skier, a professional skier, now an inventor and an entrepreneur. So is there anything this man can't do? I don't know. Let's take a few more questions. We got about 5 minutes left. We want to get to them. Marlene says, with carcinoid heart disease, do the right heart valves always show vegetation? And I'm not sure what that means. If you could.
Whenever we see a deformed, thickened valve, we have to answer the question, is it a vegetation or is it a plaque, which is characteristic of carcinoid? Serotonin stimulates receptors on the inner lining of the heart, which cause fibroblast proliferation. That means scar formation.
Okay.
So the whole inner lining of the right heart is often scarred, including the valves. And that's the plaque that we refer to of carcinoid heart disease. We refer to vegetations in somebody who has an infection, which goes to the heart valve and seeds the valve with infection. That produces a different type of scarring, which looks different, and we refer to as a vegetation.
Got it. Got it. Got it. All right. Here's a question from Sheila. Could a sclerosis focus in the rib be indicative of a possible NET metastasis?
Yeah, it's possible. Whenever there's a sclerotic lesion, it could be, but it could be other type of tumor also. So that's where our other radiology experts and our oncologists get involved, and orthopedics may get involved depending on the severity of the lesions, in order to tell us what is the likely cause of that sclerotic lesion.
Got it. Dr. Zacks, if someone is, what percentage of NET patients get carcinoid heart disease?
So, first of all, about 20% of NET patients develop the carcinoid syndrome, and of those,
Okay.
half will develop during the course of their disease carcinoid heart disease. So it's usually only syndrome patients, in other words, functional tumor patients. And those are the statistics.
And in terms of management, so if someone is new to this disease, what are those first stages of advice that you would offer for them in terms of trying to manage this disease to the best of their abilities, keep their quality of life high? What are the initial simple things that they can do?
So are you asking about carcinoid syndrome or carcinoid heart disease specifically?
Well, let's stay with carcinoid heart disease, but I'm also talking about NET patients. I mean, so if 20% of them will experience carcinoid syndrome, that's a decent amount. And I'm just trying to get to, I always like to ask, like, kind of just that first bit of advice for any NET patients, but I was asking specifically from your perspective as a cardiologist.
So I think I'll speak a little bit more generally, just to say that
fair.
If somebody has a neuroendocrine tumor of any kind, I think one of the first questions that should come up is, where is it located, and is there a way of removing the primary? That's very important. The other thing is to understand that in carcinoid syndrome, the majority of these patients have midgut carcinoids, very often in the terminal ileum as the site of the primary. And then very often, because the substances produced by tumor very often mimic other problems, they develop diarrhea sometimes, and it's misdiagnosed. And unfortunately, often it's a matter of 4 or more years until somebody says, hey, you have a specific type of tumor. And so it's important to keep in mind that if you have symptoms, find out what is the cause. If they already know it's a neuroendocrine tumor, where is the primary? Can it be removed? And then to understand that it's through the blood and the lymphatics that you get metastases. The lymphatics can give you regional lymph nodes that become metastatic with carcinoid. And the blood carries the blood to the liver, because the liver is cleaning the blood of substances. And so it filters out these tumor cells. And then that is the site of potential site of formation of metastases in the liver. So it's kind of educating people to ask the question, look, if you know I have something, where is it located? What's the extent of disease? And can I get the primary removed at least?
Perfect. Thank you. I appreciate that answer. I just want to say we have had so many beautiful comments. That's going to be our show for today. But Karen, one of many, says, thank you so much for a great show, especially as I go in for my US echo tomorrow morning. Dr. Zacks was great. And we'll send you some more of the comments, Dr. Zacks. People really, really enjoyed your answers today, and I did too. I appreciate your time. Thank you so much for being here with us.
Do we have time for one other comment?
Absolutely.
Okay, just wanted to say that the protection through procedures is very important. And the number one important protector is the monthly somatostatin analog shot. And so if you're going to have an invasive procedure, try to schedule it within 2 weeks of that monthly shot, and you may be fully protected. However, we are prepared during the procedure to give you a drip of additional octreotide, as well as a steroid to suppress vasoactive substances, which can cause a carcinoid crisis. And we have a whole protocol that's readily available. Anyone can contact me at any time on the protection through major surgery.
Amazing. Thank you for that addition. And I see a bunch of hearts and thumbs up and all these emojis that Facebook uses flooding in right now, that people seem to have really enjoyed the show. And I did too. Thank you again, Dr. Zacks.
It's my pleasure. Thank you.
Absolutely. And thank you all at home again, as always, for being here. And we hope that this program helped answer some of your questions. Again, I'll reiterate, please reach out to Carcinoid Cancer Foundation, either at carcinoid.org or private message them here on the Facebook page where you already are for further information if you have any question. As always, thanks again to our presenting sponsor, Tercera Therapeutics. We could not do this show without them. And finally, my name is Raym Bennett. Thank you for watching. I have been your host, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.